echocardiographic findings. We're going to discuss Medical Center in Cleveland, Ohio. In this video, we are going to review the normal parasternal long axis echocardiographic findings. We're going to discuss how to use this window to help differentiate a left pleural effusion from a pericardial effusion, and we will also discuss how to use this window to differentiate an epicardial fat pad from a pericardial fluid collection. Let's take a brief look at the parasternal long axis window. In this video, you'll see that it's obtained using the abdominal mode with the goal of obtaining an image that has a traditional cardiac orientation. So to do this, the transducer is placed in an imaging plane cutting from the right shoulder to the left hip, with the transducer just to the left of the sternum on the patient's chest, with the transducer somewhere between the third and fourth intercostal spaces. You can see the following image orientation: anterior, posterior, foot, head. You've got right ventricular outflow tract, intraventricular septum, left ventricle, posterior wall of the left ventricle, descending aorta, left pleural space with comet tails or ring down seen from air in the lung, left atrium, anterior leaflet of the mitral valve here opening, aortic valve, and aortic outflow tract. Let's begin by looking at how to differentiate a pericardial effusion from a left pleural effusion on the parasternal long axis window. Let's take a look at this parasternal long axis window. You can see that there is an anechoic space here anteriorly as well as posteriorly, and you can see that this goes in between the back wall or the posterior wall of the left ventricle and the descending aorta. So the fluid collection is anterior to the descending aorta, and it extends this way towards the AV groove. On the parasternal long axis window, this is the key way to distinguish a pericardial effusion from a left pleural effusion. A left pleural effusion will also be posterior to the left ventricle, but it will stop at this point here, and it will not continue anterior to the descending aorta towards the AV groove. The fact that this patient has a fluid collection anteriorly, we lose some of the apex here, but this wraps around in this direction, which is consistent with a pericardial effusion. But the big distinguishing point on the parasternal long axis window is to look at the descending aorta and to see, does the fluid go anterior to it towards the AV groove? That only happens with a pericardial effusion. In this parasternal long axis window, you can see right ventricular outflow tract, left ventricle, left atrium, aortic outflow tract. You can see here's the back wall of the left ventricle. Here's the descending aorta. There's a large anechoic fluid collection here. So you could look at this and say, maybe this is a pericardial fluid collection. However, if you look closely, you can see that this stops right at the descending aorta. It does not extend anterior to it and head towards the AV groove. So this is a left pleural effusion. If you look closely, there may be a very, very tiny pericardial effusion here, but this large fluid collection here is a left pleural effusion. And the way you know that for certain is you look at the descending aorta to see, does the fluid collection extend over the top? And in this case, it doesn't, so it's a left pleural effusion. In this parasternal long axis window, you can see that there's a very large anechoic fluid collection that extends around the heart here. And as you follow it, it goes anterior to the descending aorta and extends towards the AV groove. So this is a large pericardial effusion. You can see right here You've got an echogenic line with multiple comet tails or ring downs coming from it, which represents the lung. This is where the left pleural space is. But this large fluid collection here, because it extends anterior to the descending aorta here, is a pericardial fluid collection. While not part of not a specific part of the EFAST exam, you can also notice here that the heart is swinging within the fluid and that there's also some premature invagination of the right ventricular wall during diastole. So this was a patient who had findings of pericardial tamponade. This patient has a very small stripe posterior to the left ventricle that's really only appreciated in systole, but you can see this extending along the back wall and heading in this direction anterior to the descending aorta. So this is consistent with a small pericardial effusion. On the video clip, you can see it here, and you can see how it essentially disappears during diastole. So this is a very small pericardial fluid collection. On this video, the first thing you notice is that the patient has a very large anechoic fluid collection posterior to the left ventricle. However, as you follow it towards the descending aorta, you can see that it stops right at this point here. It does not pass anterior and extend towards the AV groove. So this large fluid collection represents a left pleural effusion. But if you take a look, there's also a more subtle fluid collection. You can see anterior to the right ventricle that there's a very small anechoic stripe that extends around here. It's predominantly seen in systole, but it extends anterior to the descending aorta. So this patient also has a very small pericardial effusion in addition to the large left pleural effusion. Let's now look at how you can distinguish a pericardial effusion from an epicardial fat pad using the parasternal long axis window. Here we have a subcostal window of a patient who had a penetrating injury to the left precordial region. The physician that was performing the FAST exam, when they performed the subcostal window, noticed this echogenic space along the right side of the heart. They felt that this was most likely an epicardial fat pad because of the consistent echogenic pattern within this region that does not change between systole and diastole. However, they weren't 100% confident, so they performed a parasternal long axis in order to gather more data to support that this is indeed a epicardial fat pad. If you look at this patient's parasternal long axis window, you can see that there is an echogenic space anterior to the right ventricular outflow tract. There's echoes contained within it, but if we follow along towards the back wall of the left ventricle, we do not see any evidence of free fluid in the pericardial space, and we do not see a left pleural effusion either. So the fact that you have this echogenic area just anteriorly in this supine patient would make it very unlikely that this represented a pericardial effusion. So this patient had an epicardial fat pad. But you can see how the addition of the parasternal long axis, when you have doubt, can be helpful in differentiating between the two entities. Let's review the key points before ending the video. Pericardial fluid will go between the posterior wall of the left ventricle, but will go anterior to the descending aorta. Left pleural fluid will also be posterior to the left ventricle, but it will not go anterior to the descending aorta. This is the key difference. With epicardial fat, it occurs anterior and along the right side of the heart, and it will not extend posterior to the left ventricle. This concludes the parasternal long axis interpretive mastery video. If you have the ability, at this time I would recommend performing the parasternal long axis window on normal subjects and identifying key sonographic landmarks. After doing this, go ahead and take the parasternal long axis quiz. I'm Dr. Robert Jones, and in this brief lecture, we're going to go over cardiac clinical applications of the EFAST exam. It's important to remember that the cardiac application, meaning the detection of hemopericardium, is one of the most important ones in the FAST exam. Studies have shown that the early detection of hemopericardium dramatically reduces the morbidity and mortality in these patients. So this is an area where you get the big bang for the buck when you perform the FAST exam. Let's first take a look at the stable patient. If there's no pericardial effusion seen, then you should go and look for other pathologic conditions. However, in the patient that you feel is high risk for having a cardiac injury, although there's no evidence-based literature to support it, I would recommend performing at least one serial scan in order to verify that no delayed hemorrhage can be detected. In the patient who is stable but has a pericardial effusion, surgical management is going to be warranted regardless of the size. This is where you're really going to reduce patient morbidity and mortality. What about if you think there may be a pericardial effusion but you're not certain? You've got a couple options in the stable patient here. Frequently scan them to assess for dynamic size change while you arrange for other imaging or surgical management. At a minimum, though, these people are going to have to be watched extremely close for any dynamic change in the size of the fluid collection, because if it truly is a hemopericardium from a penetrating cardiac injury, then these patients are at risk for sudden deterioration and they will have a very high morbidity and mortality. So these people need to be taken very seriously. Lastly, let's look at the unstable patient. In the unstable patient with a pericardial effusion, these people need emergent operative management, and that does not mean a needle pericardiocentesis. These people need to be emergently taken to the operating room. If you don't see a pericardial effusion in the unstable patient, then you should aggressively look for other causes of their instability. Lastly, what if you can't tell if they have a pericardial effusion? Or you think that there may be one, but you're not sure. This is always the tough case, and this has to be approached on a case-by-case basis. If you have a strong suspicion, but you can confirm it, most would recommend that operative management be undertaken because the risk of sudden death in these patients is very great. Now, this concludes the clinical applications lecture for the cardiac portion of the EFAST exam.